I like to talk about it any chance I get, so thank you for having me. I did do a talk to this group probably like 3 or 4 years ago. So I have obviously got lots of new information since then. So I'm just going to go over um, a couple things briefly. We did the original title was breast localization and biopsy, and we did I changed the talk a little bit because I know Dr. Yen in Parksville did talk quite a bit about how we biopsy the breast, etc., with the different modalities. So I thought I would go more back to correlation and talking about all the modalities and have included a few extra things in there. So hopefully this talk ties in very well with Dr. Yen's talk that hopefully a lot of you were able to see in Parksville. So we'll get started. So today we're going to be talking about breast imaging and how it is such a multimodality approach and how we correlate not just with mammogram and ultrasound, but also with MRI and how we use the different modalities in breast imaging. So we have lots of different breast imaging procedures. So the full field 2D digital mammography is the gold. Oh my goodness, I'm not too sure why it's doing that. I'll just see if it'll go one at a time here. Okay, sorry about that. So full field 2D digital mammography is the gold standard for screening and diagnosis of breast tissue. And as lots of you know, we have 3D breast imaging or digital breast tomosynthesis now at a few sites on the island. So VGH being one, CDH, and more recently NRGH. So we're all very excited to have Tomo. It has really added a lot to our workflow and diagnosis. So we're very much enjoying that. So Tomo, of you who don't know, is 3D slices of the breast, and it basically what it does is it diminishes the effects of overlapping tissue, which is fantastic because a 2D mammogram, when we compress the breast, that is one of the biggest barriers that we have with 2D mammography is the overlapping tissue. So the nice thing about tomosynthesis is it takes slices through the breast and it helps us figure out, what is overlapping tissue and what could be a true mass or architecture that we're looking for. So when we speak about adjunctive imaging tests, there are a few here that we're using. So the most common is targeted breast ultrasound. And what that is doing, it's targeting the abnormality that we see on mammogram or palpable abnormality and limited to the quadrant of the breast where we're seeing the abnormalities. So we're not ultrasounding the whole breast when we're doing targeted breast ultrasound, as the name suggests. We're also using MRI, or breast magnetic resonance imaging, is a very helpful tool with preoperative breast MRIs as well as our high-risk patients. Contrast enhanced mammography is something you may all be hearing about. It's very commonly used out in Ontario, more so in places where they don't have a lot of ability to do breast MRI. We're very lucky here, especially in South Island and even in Nanaimo and Comox now, we do have more ability to MRI. So contrast enhanced mammography is kind of like we call it the poor man's breast MRI. So luckily, even though we seem to be poor in many areas in British Columbia, MRI is not one of them. So we're not implementing contrast enhanced mammography or using it here on the island. And then also you'll hear of a lot of patients going for PET or positron emission tomography. Now PET is used more to assess distant metastases, but quite often we will see patients coming back in for a workup that have had a PET scan. Maybe they're battling ovarian cancer or some other cancer, but then there might be some enhancement uh, or some pickup in the breast that will prompt a mammogram and targeted breast ultrasound after the patient has had PET. So those are the adjunctive tools that we use. Now, when we talk about supplemental tools, we're talking about supplemental breast ultrasound screening for women with dense breasts. So there's two ways that we can supplement digital mammogram, and that is with automated breast ultrasound screening or handheld breast ultrasound screening. So we'll go more into that as we work through the presentation. So just a quick recap, I know you all know what a screening mammogram is, but a screening mammogram is an X-ray of the breast. We do 4 standard images, 2 CC views, 2 MLO views to detect early breast cancer in asymptomatic women. The guidelines, which we've held on very well to here in British Columbia as compared to other provinces, women can start screening mammography at age 40. So I always encourage any patient at age 40, whether they have family history or not, to have a discussion with their doctor and come in for their screening mammogram. We're catching early breast cancers every day, and if you can have a mammogram at 40, you should. So now what are the frequencies? So we want patients starting at 40 to 74 with a first degree, if you have a first degree family relative with breast cancer, so that being mother, sister, daughter, father, brother, or son, we want you to come to the program every year. If you're 40 to 49 and you don't have a family history, this is about talking to your doctor about the benefits and limitations of screening mammography. And to me, there's only a benefit of coming. So please try and encourage patients. I know some GPs say to doctors, oh, don't start till you're 50 or after menopause because your breast will be dense. There are so many 40-year-olds walking around there with fatty replaced breasts, and it would be very easy to see a cancer on their mammogram. So until you have your first mammogram and you know your breast density, you don't know what your breast density tissue type is. So come in at 40 for that first mammogram and then move forward from there. So we do want everyone starting the program at 50 to 74. And if you have no family history, they want you coming every 2 years for your exam. Now, why do they put this cap on there of 74? I'm not too sure. They used to, in British Columbia, have starting at 40 till death do us part, which I thought was great because it just left that window open for the elderly women to keep coming in. Not that 74 is really elderly. Um, so we want women to continue coming after 74. They did put that cap on there because they're saying they want them assessed by their doctor. And if they're healthy women, they need to keep coming because our two main risk factors for developing breast cancer are being female and aging. So those are two things we can't get away from. So we want those healthy 74-year-old women to keep coming. They put that on there. So let's say we had a 75-year-old that was very sick with maybe other types of cancers or had COPD or just, they didn't expect their life expectancy to be more than 10 years. So in that case, they're probably not going to benefit from screening mammography, but I find most of our 74, 75-year-olds are super healthy. So we want to keep encouraging people to come to the screening mammography program. Okay, so the one thing we do know is screening mammograms truly save lives. So we can find a cancer as small as 2 millimeters on a screening mammogram. And when we find cancers that early in the breast, it allows for more treatment options and better prognosis. And family history does play into it, but really at the end of the day, 1 out of 8 women in BC that live to be 80 will get breast cancer in their lifetime. So it doesn't take long to think of 8 women that you know, and one of those women is going to get breast cancer. So have your screening mammograms. It really does work. And, we all bounce back, not like in the picture there. So don't worry. All right, so moving on to diagnostic mammography. So we get all our women into the screening program. Participation rate is going up. That is the one thing I want to let people know for screening mammography. It was hovering around 50% for years. It is moving up, and that's why we have wait lists. We've actually expanded our screening hours down here in Victoria till 11 p.m. every night, so Monday through Friday. So we are getting more people in. So we are getting the word out there. So just keep promoting screening mammography. So The next thing is diagnostic mammography. So who comes in for diagnostic mammogram? So anyone from the screening mammography program that has an abnormal screen. So basically 7% of our screening patients do come back for extra pictures. So if you think we do 100 mammograms, we're going to call 7 of those mammograms back for extra pictures, and we're going to find, maybe one cancer. So I think the formula is 1,000 mammograms, 70 workups, 4 cancers. So we have to screen a lot of people to find a very small amount of cancers, but that's what we do. So when someone gets an abnormal screening mammogram, they note on the requisition, is it A, low suspicion? Is it B, moderate, or C, high suspicion? So most people that get a call back have a suspicion. And what we can tell those people when we get them to come back is, 90% of these abnormalities turn out to be overlapping tissue or something benign. Try not to worry too much. Now, I only say that to the women that have a suspicion. The ones that have B and C, we do have to word that a little bit differently, saying there is something we saw in your breast that we are concerned about, and we do want to do some extra imaging, which may include mammography and ultrasound and a possible biopsy. So we're not wanting to lead those people, women, down the garden path, but we're also not wanting to instill panic in the other 95% of the women that things are going to turn out fine. And so that's kind of the way we do it here. And I'm sure it's very similar across the island. So the other people we're getting into diagnostic that don't qualify for screening mammogram are those patients that have had previous breast cancer. So they all need a doctor's requisition every year and to have a mammogram every year. Patients with breast implants also need a doctor's requisition. And again, this is all based on family history. If the patient is with breast implants and they have no family history, we're going to see them every 2 years. If they do have first degree family history, we're going to see them every year. So there's lots of extra things here once we get patients into diagnostic. We always start with the 4 basic images, 2 CC and 2 MLO. Now, if we see something in the breast, we may need to do extra views. So if we have 3D mammography and we were going to do a spot view, we actually do a TOMO now, which is the 3D mammogram. In places where they still have 2D, they're still doing a lot of spot views and roll compression views. And, that's just kind of how the workflows change moving from 2D to 3D. Ultrasound is our most common adjunctive tool. So to me, mammography and ultrasound go hand in hand. So the more time as sonographers, you can talk to your mammographer, ask them what they're seeing, talk to the radiologist before you do the ultrasound to correlate the mammogram. That's how you're going to have the most success with ultrasound. And the mammogram gives so many hints as a sonographer. So I'll kind of go into that as we move through the slides. So also we use breast MRI very commonly. We'll go through further indications for MRI. And then we're doing a lot of tissue biopsies, and we can do that with the mammogram machine, the ultrasound, or MRI. Now, ultrasound is our go-to for breast biopsy. I would say we do 85% of our biopsies under ultrasound. So I'm sure you have all seen many, many breast ultrasound biopsies because ultrasound is the preferred method. We're also doing fine wire localizations prior to surgical intervention and sentinel node. So again, depending on how the lesion and the cancer was detected with which modality we use the biopsy is how we put the fine wire in. So if the lesion was biopsied with ultrasound, we are going to be inserting that preoperative fine wire localization in with ultrasound. If the biopsy was done with the mammogram machine, either using stereotactic or tomo biopsy, we will also insert the wire with the stereo or tomo biopsy. Now MRI, there are 2 places on the island where we're doing MR biopsy. That's Victoria and Nanaimo. So anytime we do an MR breast biopsy, which is maybe in 2 or 3% of our patients, only if the imaging is occult on both mammo and ultrasound, and we can only see the abnormality on MRI, will we do the biopsy there. We leave a tissue clip after the MRI. So what that allows us to do is if that MRI biopsy does turn out to be cancer, there's a clip in there that we can localize with the mammogram machine using stereo or tomo biopsy and put the wire loc in that way. Okay, we'll just keep moving on. So indications for targeted breast ultrasound as an adjunctive tool. So mammographic abnormalities. So those are things that we're looking for. They will guide you if you're looking for a mass, an asymmetry, architectural distortion. We don't do targeted ultrasound a lot for groups of calcifications, only when we feel that group of calcifications is associated with a mass or the group is really large, then we might have a good chance of seeing it with ultrasound. But quite often, those will go to stereo or or tomo biopsy. We're always going to do ultrasound for palpable abnormalities such as lumps, thickening, dimpling, or puckering of the skin, or from nipple discharge if it's bloody or clear. Women who are pregnant or lactating or under 35 years of age with a clinical breast concern. So we use ultrasound as a first tool for women that are pregnant and lactating, just because the milk pretty much causes, well, the pregnancy increases the density of the breast. And then when they start lactating, the milk kind of causes the breast to be almost a whiteout. So that's why we're using ultrasound as our first tool. And we are doing mammography first on women 35 years of age or lower, but if the woman is 34, we are going to start with a breast ultrasound. So further evaluation of suspicious lesions found during supplemental breast ultrasound screening exams will require a targeted handheld ultrasound, and evaluation purposes for determining this extent of malignancy, as well as guiding those interventional procedures as we talked about before. And I'm sure this is everyone's favorite. These are the most difficult second look breast ultrasound biopsies. So what we do is quite often here in Victoria, we are doing a mammogram and ultrasound. We find something suspicious. We do the biopsy, and if this woman has C or D density breast, we send her for a preoperative breast MRI. And in some cases, this preoperative breast MRI can show us if there's multifocal, multicentric, or contralateral breast disease, and then they have to come back for a second look ultrasound, and then it's up to us to find that very subtle thing that's going to be showing up on ultrasound that corresponds to the MRI. So I just kind of told you everything about MRI, but I'll go through this just to highlight the parts that I missed. So when are we using breast MRI? Well, preoperative is one of the main reasons why we use it. The other reason is screening for high-risk patients. So it's those patients that have gone to the hereditary breast cancer and they have been deemed a high lifetime risk of developing breast cancer and have the BRCA1 or 2 gene. So these patients will be undergoing annual mammography, hopefully with tomo. If they're at a site that does tomo, we go straight to tomo for these high-risk patients. And then either shortly after that mammogram or staggered 6 months apart, then they're having their breast MRI. And they're doing mammogram and breast MRI annually. And then what we will do is we use ultrasound as an adjunctive tool if we have a question we need to answer from the mammogram or the MRI. So also that falls under this indication for MRIs, women that have had chest wall radiation between 10 and 30 years of age. So this is less common now, but women that had lymphoma or non-Hodgkin's lymphoma at a young age, they were giving full chest wall radiation. Most of those patients we can see a breast cancer develop at a very young age and close to the chest wall. So those patients are also having annual MRI with their mammograms. Occult breast cancer. So when we can't find them, when we're suspecting or can't find a mammogram, a breast cancer on a mammogram or ultrasound, but we're suspecting something's there. That's called occult on mammogram and ultrasound. So we're going to turn to MRI. That's going to show us MRI is the most sensitive out of all breast imaging tools, but is also the least specific, but it can help us find an occult breast cancer. The other reason why we know someone has an occult breast cancer is, say they have a very large lymph node. We've biopsied that lymph node. It says it's metastatic from a breast cancer, but we can't find a breast cancer anywhere on mammogram and ultrasound. Those patients are going to go to MRI. And we did talk a lot about these preoperative MRIs that we do in women with biopsy-proven CA to rule out. Now, multifocal is a cancer close to the main cancer, so in the same, and the way I like to think of multifocal cancer, it's kind of the same focus within 5 centimeters. Multicentric is when we're seeing a cancer in a different quadrant of the breast. And once something becomes a cancer becomes over 5 centimeters, or it's covering 2 quadrants of the breast, that patient most likely may have a mastectomy as opposed to a lumpectomy for a solitary or a multifocal cancer. And then we're also looking, is there a contralateral cancer? That's the great part of MRI. It can tell us if there's something subtle going on the other side. So I think basically what they're doing in areas where they don't have access to MRI and they have contrast enhanced mammography, then they are using contrast enhanced mammography in these situations. But it's much quicker to do an MRI, and it just gives, we love breast MRI in these situations. It's really helpful tool. So let's say a patient goes for surgery, has the lumpectomy, has the cancer out, but there's positive margins on the pathology. You'll quite often see them order MRI to see, is this post-surgical, are there still positive margins left on imaging? Quite often, sometimes we may come up against a post-surgical scar that's increasing in size. So, oh, is that a recurrent tumor or what's happening there? MRI can give us, can be very helpful in those situations. And also, how is this patient responding to chemotherapy? So in these cancers where the cancer is very large, over 5 centimeters with spread already to the lymph nodes, what they're doing a lot in these cases is deciding to do neoadjuvant chemotherapy. So we're putting a little tiny tissue marker in the main lesion before they start neoadjuvant, and then they're giving this chemotherapy in hopes of shrinking the tumor so that they can get better margins when they do take the cancer out. So that may be, you may be asked to monitor this patient with ultrasound. Quite often they're doing it with MRI, so you may see a lot of neoadjuvant patients coming back to monitor how the lesion is shrinking. So when we come up with breast implant complications, such as intra or extracapsular rupture, or post-implant complications, we are assessing those with ultrasound. It can get pretty tricky with ultrasound. So quite often, if it's something we want to solve and we just can't figure it out on ultrasound, they will order a non-contrast breast implant MRI, and that helps us check out the implant and see exactly what's going on in there. And also we may use MRI in problem solving. Basically, we like to exhaust all our mammogram and ultrasound options first before we just order someone for a problem solving MRI. But sometimes we just get to that point where we're like, we need to have the ultrasound to figure, or the MRI to figure out what's going on, because the mammogram and the ultrasound hasn't quite given us enough information. So moving on from there, what I would like to talk about a little bit is breast density, because I'm sure you've all heard a lot about breast density, and you're maybe wondering how to explain that a little bit better to your patients. The mammographers at your facility, they should have these handouts in your area. So if you do feel like you're trying to talk a lot about breast density to patients, you can ask your mammographer if they can order these from the screening program, and they're very useful to give out to the patients that have questions. So basically, you're going to see BI-RADS A and B. Those are what we consider fatty breast tissue. So A is the breasts are almost entirely fatty. B is there are scattered areas of fibroglandular density. So patients that fit into this category, Mammography is more than enough to assess their breast, detect an early cancer, so there would be no supplemental screening suggested for these women. So now this white dot here depicts the cancer. You can see as the breasts get more dense in the C and D, which is considered dense breasts, the white dot gets harder and harder to see. Now, luckily, only 10% of patients are D-density breasts because those are the ones that 100% need supplemental breast ultrasound screening. We really need that supplemental breast ultrasound to see if there's a cancer hiding in those breasts. So C, the definition there is the breasts are heterogeneously dense, which may obscure small mass, and D, the breasts are extremely dense, which lowers the sensitivity of mammography. So there's no debate that these extremely dense breasts do decrease the sensitivity in mammography. And now, luckily, here in Victoria, we do have the ability to offer supplemental breast screening to women. So I'm going to go through that. So this supplemental breast ultrasound screening for women with dense breasts. So who's eligible? So a woman that has had a current mammogram with CRD density breast score. And people may think, oh, I have dense breasts, but they're sometimes breasts can feel like they're dense or ropey, but they're actually just filling fat lobules. So until you have had your first mammogram and you've been awarded your breast density score, you really don't know what your breast density is. So if you have a current mammogram and you have a CRD density breast and you are interested, patients are interested in saying, what else can I do? How can we see through this dense breast tissue? With a doctor or nurse practitioner needs to send a referral, and they would be able to have that supplemental breast ultrasound screening done. So again, what is the frequency? So it's the same as what the screening mammography program follows. So it's annual if the patient has first-degree family history, or it's every 2 years if the patient has no family history. So the good thing is the screening mammogram, you don't need a doctor or nurse practitioner referral to get in. You just need to make sure you're eligible, and you can book your appointment online. You can call the 1-800 number and book that appointment. You just need to have a doctor or nurse practitioner to tell them who to follow up the results with. Now, the difference is for the supplemental breast ultrasound screening exam, you do need a physical doctor's referral. So these women need to go with their current mammogram and breast density score and talk to their GPs and say, I have CRD density breast and I would like to have a supplemental breast ultrasound screening. So where is this done? It hasn't been till just recently that we've been able to get a little bit of infrastructure that we can actually provide these exams for patients now instead of sending them over to Vancouver. So in Island Health, we're currently doing them in South Island, and we're doing a handheld breast ultrasound screening technique that is in the evening appointments. So we do have breast ultrasound running here from 3 in the afternoon till 11 o'clock at night. So I think we're doing maybe 3 breast ultrasound screening appointments a night, sometimes 4. And at West Coast Medical Imaging, so those are day-hour appointments, and those exams are performed with automated breast ultrasound screening. So either place, you get sort of the same exam. It's just the images are acquired differently. The only thing you need to be aware of if you are referring a woman with breast implants, that can only be done the handheld way. So they must come to VGH. Okay. So what is handheld breast supplemental ultrasound screening? Well, it's much as you imagine, it's like targeted, but we're doing the entire bilateral breast tissue. So what I say to technologists when they're switching from targeted breast ultrasound in a diagnostic setting to supplemental breast ultrasound screening handheld, you have to switch your frame of mind. So you need to go to, okay, this woman is here for screening. We're looking to see if there's an abnormality in her breast, but it's not like you're targeting in or you have a target. So you need to just stick with the program. You need to sort of scan through both breasts methodically. We do have there is a protocol for that. So if you're interested, you could look there. We're stopping and taking pictures of anything that looks suspicious or solid. That must be properly documented in 2 views with all the measurements. We do document cysts, but more just which is the biggest cyst, where are they, one picture. You're not going to go into measuring every single cyst, or you could be there all day. So the bilateral breasts are scanned. The great thing is when you're doing handheld screening, we can do some measurements. We can also do Doppler if we find a suspicious area. We can look in the axilla as well. So images can be acquired while you're scanning, and a final recommendation can be made without them coming back. So the thing is, we only want very experienced breast sonographers doing the handheld breast ultrasound screening, because the technologist is in charge of this exam. You are the radiologist's eyes. You are stopping and you're taking pictures on the areas that look suspicious or solid. So you really have needed to see a lot of breast pathology to be very effective with handheld. So the next way and how they're screening breasts at West Coast Medical Imaging is with the automated breast ultrasound screening. Now, the great thing about ABIS is it's less operator dependent, and it can be performed by either a sonographer or a mammographer. So both are being trained on this tool, and at West Coast they do have sonographers doing this exam as well as mammographers. So it is really a great model that both modalities, both technologists can be trained. So the entire breast is imaged and reviewed later. The downfall of ABIS is when a concern is seen on ABIS, the patient will have to return for targeted breast ultrasound at a diagnostic center to determine appropriate care. So ABIS is it separates the acquisition and the interpretation. So it's an automated one button acquisition. So here you can see the sonographer or the mammographer, whoever is performing this exam. It's a 15 centimeter field of view reverse curve transducer, and they do say it takes less than 3-minute scan for each breast with a total exam time of 15. I do think it might take a bit longer than that once you get really experienced. I think that probably is a reasonable time frame. And then what happens is those images are then sent to be interpreted later. So the workstation you see is how the radiologists see it. So they see it in a coronal view as well, and that's how they do most of their reading, scrolling through on the coronal view, and it acquires 3 sweeps of each breast. So there's 6 sweeps altogether that need to be evaluated. Now, I know that a lot of people are interested in learning more about ABIS and how it works. So Jen and I have actually set up a full talk about ABIS on April 23rd. So I'm just kind of giving the Coles notes here, but if you're interested in learning more about ABIS, then you can tune in then on April 23rd, and we'll have a full presentation for that. Oh, and the one thing I missed that some people might be thinking, well, how long does it take to do a handheld exam? It takes between 30 to 40 minutes. So here in Victoria, we're giving 40 minutes to do that scan. I would rather have that little bit of extra time. Some breasts, when you're doing the handheld, there's nothing in them except for density, but you're having to scan through to see if there's anything there. Some breasts, even the very small ones, they pack a punch. There can be lots of stuff in there. So those ones may take longer to scan and of course write up. So we want to make sure everyone has the appropriate time to perform these exams. So moving forward then, handheld or ABIS is a supplemental breast ultrasound screening exam, and it's not a replacement for mammography. So that's one of these big take-home messages that I don't want to get things confused. Everyone still needs a mammogram. Mammogram is the gold standard for early detection, and we really need that mammogram to have an overall picture of what's going on in the breast, and then we use ultrasound after that. So the mammogram can give lots of hints as what you're going to see on the ultrasound. So that's what we're going to discuss further here. So when you're doing mammography and breast ultrasound, correlation is the key. So we need to know what the mammographers are thinking and what the sonographers are thinking, and try to transfer that information over to the sonographers so you guys can find what you're looking for. So here's an example of a mammogram and an ultrasound happening on the same day. That is me. Jen was bugging me. She's like, how old were you in that picture? So yeah, I guess that was quite a long time ago where we could wear rings and watches at work. So I would venture to say that was back around 2007-ish. Yeah, many years ago. Okay, so we've got the mammogram and the ultrasound. So mammographers are used to looking at the images as we see them on the left, and as sonographers, you're looking at the image on the right, which is the clock position. So what you might be asking as a breast sonographer is like, okay, how am I going to take that mammogram and translate it into my clock face? So there is a very easy technique to do that, and I'm sure most of you know how to do that already, but we'll just kind of go over this quickly. So triangulation and correlation is the key. So triangulation of a solid lesion on a standard mammogram and correlation of a lesion with all imaging modalities. We're using hints such as location, size, shape, and surrounding tissue. So mammographic triangulation, how does that work? So when we're doing a mammogram, we want to know, is the lesion real or is it superimposition of the breast structures? So for us to prove that a lesion is real, we must visualize that lesion in two different planes. So we need to see it on the CC and the MLO. And that may be a lot of work for the mammographer because sometimes you can see it on one view, but you can't see it on the other. You're pretty sure it's there. So they might need to produce some extra views for you to be able to show you where the lesion is. And to be able to do that, we're doing either tomosynthesis, if you're lucky enough to have that imaging technique. It is really helpful, or these additional mammographic views. And even sometimes lesions are located, not in the plane of view. So we're having to turn the patient or really try to manipulate them into the machine to get those spots on the mammogram that aren't showing up. So we get pretty creative. We can do rolled views, axillary tail views, cleavage views. We have one that we call the Cleopatra view. We get very inventive in there, trying to get these real lesions on two different views to hopefully be able to give you more instruction how to target this lesion and find it on the ultrasound. So the one thing as mammographers, you'll quite often probably hear mammographers saying, oh, I did the CC and the MLO. Those are the two standard views, but I did a 90. So a 90 is either a lateral medial or a medial lateral view. So it's a true 90 view. And why we do these 90 views is say we see something on the MLO, but we're not sure where it is on the CC. We know that lateral lesions on a 90 move down in the breast. So we say lead falls, or medial lesions rise up in the breast. Medial muffins rise. I don't know. We come up with all these strange ways to describe how lesions move in the breast, but it does kind of stick in your head. So if you're trying to figure out where a lesion is, you could talk to the person that did the mammogram and say, hey, do you think it's in the lateral part of the breast, the medial part of the breast? It can really give you a lot of hints when you're looking around for something. So let's triangulate this from the mammogram onto the clock face position. So we've got the right CC and MLO. Those are our standard views. And we have this yellow line. It's an imaginary line that mammographers use. It's called the PNL, or the posterior nipple line. And it is a perpendicular line we draw from the nipple to the chest wall. And so this here is the pectoralis muscle. So we take this line, and when we're drawing a clock face, the PNL intersects like this on the right breast, and this way the other way on the left breast. So we use this PNL as a way to triangulate here onto the clock face. So I'll go over the next stage here, trying to describe it a little bit better for you. So is the lesion real? Well, we can see it in two views here. So we can see the lesion is real. We can see it on the CC, and we can see it on the MLO view. So we know it's real. We're going to be looking for a mass. Where is it in the breast? Where's the depth? That is also great information to give the sonographer. Is it in the anterior, middle, or posterior part of the breast? And what is the distance from the nipple? The distance from the nipple really does help you find the lesion a little bit easier. And it actually, I would say, when we say it's not mandatory, but it's useful, well, we are actually mandated to draw or to measure the distance from a lesion to the nipple here in our breast ultrasound department because it is such useful information to the surgeon. So that is part of protocol. And here's this line diagram. So any of your mammographers will probably have this sheet, and we kind of photocopy it. We cut it up into little squares, and we use it to draw and to correlate where we think we're going to find lesions. And this is how we communicate to our sonographers. So here's the first case study. So basically what we are seeing here is a mass in the breast. We can see it. This is the right CC and the right MLO. The lesion is the same distance back from the nipple in both, so we know that it's real and we know that that's the same lesion. So let's send that for ultrasound and see if that's a solid or cystic mass. But first we want to tell the sonographer where that mass is. So what we do, oh, sorry, my lines are a little bit off here on my presentation. Just a sec. This line should be here. Oops, sorry. And this line should be here. So what we can see is this lesion is in the middle of the breast here, directly behind the nipple, and the P&L should be up here. It's just below. So what we do is we want to draw this here. So on the CC, it's just lateral. Sorry, let's disregard this. We're just going to throw this slide out because it just wasn't overlaying the way I wanted it to. This one here, luckily, is overlaying the way I want it to. So on the cranial caudal view, here is your posterior nipple line. So you can see this is indicating the medial part of the breast, or the middle part of the breast, and your lesion is to the lateral. So this is the axilla or lateral part of the breast. This is the medial part of the breast. So we know that the lesion is lateral. So what we want to do is draw a dotted line perpendicular to the P&L on the clock face diagram, either lateral, central, or medial in the breast based on the location of the lesion in the CC. So we know that it's lateral, so I'm going to draw that nipple perpendicular, and I draw a dotted line like this down. So we know for sure we're going to find this lesion in the lateral part of the right breast. So here is our MLO. This is superior, this is inferior. Here's your posterior nipple line, and the lesion is just above the P&L. So then what you want to do is take a dotted line parallel to the P&L on the clock face diagram. So it's either going to be superior, central, or inferior based on the location of the lesion in the MLO. So here's your posterior nipple line, which is that imaginary line, and we know this lesion is above, so I'm drawing a dotted line parallel along that line. So now in this diagram, we can see where the area intersects, and it is in the right breast at 10 o'clock. So it intersects at the right breast, located where the dotted lines intersect at 10 o'clock. And so this diagram was basically attached to the requisition and sent along with the rec and put in the box for ultrasound. And this is exactly where the sonographer found the lesion. So they did a targeted right breast ultrasound, and it demonstrated a mass in the upper outer quadrant at 10 o'clock in the middle third of the breast from the nipple. And this was a biopsy proven invasive ductal carcinoma of this breast. So what we would have done is we can see here how this is a hypoechoic lesion. It's irregular margins. It definitely fits the criteria for biopsy. We had put in color flow on this. There was a little bit of color flow. We would have measured the lesion to the nipple. So we have that measurement there for the breast surgeon. We would have also scanned the rest of the breast to make sure there was no other lesion within the breast, and we would have interrogated the axilla too to make sure that there was no spread of disease to the axilla, then this area would have been biopsied. Now, when we look at this patient's mammogram, she's not super dense. I would say this is a B density breast. So this patient would not have gone for preoperative breast MRI. So it's very important to make sure this is the only cancer that they have in this breast. They're not having that second check with the preoperative breast MRI, but they don't need it because the breast is about a B density. So we've done our job here by diagnosing this cancer. It's a solitary mass. She had no spread to the lymph nodes. So this would be taken out with a lumpectomy and then sent to the cancer clinic to determine her treatment. So this is the next case study that we have. So this is another mammogram. Now this would be considered a C density breast. She still has a lot of fatty tissue in her breast because this gray tissue is all fatty. The white tissue is a gland, but the gland tissue is quite concentrated here. So when we have an area of concentrated glandular tissue like this, it could potentially obscure a mass. So it would be a C density. So in this screening mammogram, the only thing that we could find that looked abnormal was this little radiodense mass here. Kind of looks like a little triangle. And you're like, can't see it on the CC, but the radiologist called this asymmetry, whereas you remember case 1 was a mass. We could see it in 2 views. We know it's a mass. This one, we can only see it in 1 view. We call it an asymmetry, but it looks real. We need to figure out where it is. So that's where the mammographer does some extra views. So in this one, we did a extended view to get around into the axilla, and this is a spot compression. So this is how we did our views before tomosynthesis. Sorry, my arrows are a little off here, but this is the abnormality seen on the MLO, which we spot compressed, and we can see in fact that it's real. And then we did a view where we pulled the lateral tissue around, and yes, look at this, we can see the little mass there. So on this first view, the mass is hiding off of here, which happens on a CC view. This is the standard view. The MLO shows almost all the breast tissue, so we're always going to see more tissue and things on an MLO, and quite often we're trying to find it on a CC. Is it off the image? Is it lateral? Is it central? Is it medial? This one happens to be lateral, and there it is. So what we are going to do is we're going to send this for ultrasound. So we've been able to find where it is on the CC and the MLO. So we know that this lesion is very, very lateral on the CC. So we're going to draw this line as far over lateral as we can, perpendicular to the PNL. And on the MLO, we can see that it is above the PNL. And so that line is far above the PNL. So we're going to find that lesion in the left breast, probably between 1 and 2 o'clock, very lateral. It's in the posterior third. And sure enough, with our trusty ultrasound, this is exactly where we find this cancer. It's a very small cancer. It's about 5 millimeters. It's 6 centimeters from the nipple, and this was a biopsy proven lesion, and it turned out to be DCIS grade 1. So this lesion would have been excised, and then the full pathology would have let us know, was there any invasive component, and then they would have moved forward from there to see if they needed to do what treatments she needed at the cancer clinic. But this is where mammography and ultrasound, when you use them in conjunction, we're finding these very small, non-palpable screen detected cancers. And that's a great day of work. That's exactly what we want to do. So talking about location now between the 3 different modalities, I consider, I don't know, I guess when I was trying to make this up, I'm trying to think of how can we describe how the lesion moves from mammography to ultrasound to MRI. And I love ice cream, so I thought this would be a good slide. So mammography, the breast is pulled out on the compression paddle and it's compressed, and the nipple is pulled right out. The breast tissue is that's how we see the breast tissue the best, and all in one view is on the mammogram. So then we find a lesion on mammogram and we send them to ultrasound. Well, ultrasound, we know that they're lying on their back and the breast just kind of falls into itself. So I'm sure you've all experienced this as sonographers. We do need to kind of use a sponge to rotate these ladies at least 30 to 40 degrees over onto their hips so we can get the nipple pointing straight up to the ceiling. So we can image. Now, quite often, if we're going for a medial lesion, we're going to want to lie the patient a little bit flatter, so the medial part of the breast is flatter. If we're going for a lateral lesion, we might need to over-rotate them. But the breast does move around like this ice cream cone melting and going off kilter. The lesions are going to look much closer to the chest wall because on the mammogram, they're so pulled out. So you do have to know, and it really, all you have to do is think of how a mammogram's acquired, how an ultrasound's acquired. It's easy to imagine how these lesions move around. And then on MRI, the lesion is even going to look a little bit different because the patient is lying on their stomach with their breast falling pendulous through these two holes. So, you know, correlation is not an easy job, and the lesions can move around in the breast. So this is our third case study, and this is just to show you how these lesions are moving around in the breast and how each modality is so important for us to figure out what's going on in this patient. So this patient was a 42-year-old patient with a right breast mass. The mammogram showed a large spiculated mass in the right upper central breast, close to the chest wall, with almost 3 additional smaller satellite lesions. So here and here, you know, it's this is a very large palpable cancer in a very young woman. So when we do the ultrasound, we're measuring here the patient was positioned supine in the posterior oblique position with the armpit or with the arm above the head and the hand placed above the head, and that's to thin and flatten the breast, and the lesion will appear closer to the chest wall in this picture. So you can see in the mammogram how it's pulled out, and in the ultrasound here you have your pec muscle. It's sitting very close down to the lesion. And then here is the axilla. So we're assessing the breast lesion, but we're also going up to the axilla, and this does look like a suspicious lymph node where you can see that most of the fatty hilum has been eaten away by the cancer. So we went ahead and we biopsied this lesion, and it's probably multifocal disease with a right breast lesion. So this patient had dense breasts. She does have a large cancer in there where there is satellite lesions. So we really need an MR to kind of get the full picture of what's going on for this lady, because quite often the size can be underestimated on mammo and ultrasound, and MRI can give us a truer picture of size. So here we have the MRI, and this is showing a large irregular spiculated, strongly enhancing mass in the central breast that extends medially, laterally, and superiorly with 3 smaller satellites. So 1, 2, 3. This is probably all together, and these are the satellites here. The maximal diameter is 8.5 centimeters. So she's got, it's not multifocal, it's multicentric because it's definitely taking up more quadrants. It's larger than 5 centimeters, it's 8.5 centimeters, and she has probable metastases to one of the axillary lymph nodes. So this patient most likely, you know, she's going to be referred to the cancer clinic and a breast surgeon. She may have neoadjuvant therapy before, probably is going to have a mastectomy, you know, based on the size of this lesion. So the one thing is when we're scanning, everything's real time. That's what we love about ultrasound is we can see the image right in front of us real time. And you know, there's a lot of rotation and compression color Doppler that we need to use. So when I'm rotating, I almost feel like I'm rotating a martini glass or a glass of wine. So you like to stay on the lesion as you're rotating it so you can see. We're going to compress the lesion and we're going to look for color flow. So we're also, when we're ultrasounding, we're looking for the size. So when, so you're going to look on the mammogram. What we quite often do here for our sonographers is we will measure the size, and we're going to put that on the little ticket we send you for the targeted breast ultrasound where you're expecting to find it. We measure the size for the sonographer to say what the size they can be looking for. You can also look on the mammogram to see the shape of what you're looking for. and the surrounding tissue. So review the surrounding tissue on the mammogram. Is it in a fatty breast? Is it in a dense breast when you're searching for those difficult lesions? So here is a case study showing the location, size, shape, and surrounding tissue. So this here is your mammogram. Again, this is between a B and a C density breast. This patient has clearly a mass. It's the same because it's the same distance back from both views. It's the same shape, and we can see it in two views. So we're looking for a mass here. So we can see that on the CC, it's slightly lateral. So here's your PNL, it's slightly lateral, and here's your PNL here, and it's going to be lower. So that's where we've marked it here on our little mammo diagram. So just slightly lateral to the medial and below. So we draw our line closer into the nipple because we know it's not, we know it's close to the nipple, but just lateral. So here's our perpendicular line to the P&L drawn, and then we know it's quite low. So we've taken the MLO and drawn that parallel to the P&L, and where they intersect, we should find this around 4 or 5 o'clock on the left breast. And here we do find it, but you know, you would expect that that's going to pop out and hit you right between the eyes, but this ends up being one of those isoechoic lesions. So, you know, it might not be apparent right away, but we know 100% we're looking for something on a mammogram. And this is where the size and the shape and the surrounding tissue can really help you when you're come across these isoechoic lesions. So, you know, it's on the mammogram. Don't give up. You might think, am I scanning the wrong breast? Go back, no, it's the left breast. Recorrelate, look at the shape on the mammogram, and then this isoechoic lesion will become more apparent to you because you know where you're looking for and what you expect to see. And this ended up, this cancer here actually ended up being a mucinous carcinoma, which is, it's a type of invasive cancer, but what is making this lesion harder to see is that it's full of mucin. So it's like kind of like a thick sort of fluid, and you can kind of see it like salt and peppery a little bit. And that's why it's not spiculated, it's more rounded. And that's what these mucinous cancers can present like. So we've got 2 more case studies. I'm not too sure how we're doing for time. Oh my goodness. Okay, well, we'll just go quite quickly. I hope everybody can stay because I've got 2 great cases left here. So this is a screening mammogram, non-palpable mass, little tiny cancer in a 62-year-old woman. It's very far medial in the breast and above the PNL. So here we go. The lesion is very far medial. So we're looking by the, almost by the sternum here and above. That's where we should find it. I was involved in this case. We looked and looked. All we could see was like this vessel. We just could not find this little cancer. So we didn't give up. We biopsied it with our stereotactic machine. It was in fact a cancer. We're like, why couldn't we see this? And then I went back and really thought about the perimeter of the breast. And a lot of times these lesions can be so far over medial on the sternum, you really need to remember that the breast tissue starts up at the clavicle and goes down in the breast. So when you can't find these little things that you just know should be there, think perimeter. Think, can it be very far medial? Can it be really high up? Because the breast goes as high as the clavicle. So start your scan at the clavicle, go all the way over to the sternum and out to the mid-axillary line and really look for those. So she came back for a wire localization, and then we got super smart and we're like, thought of the perimeter of the breast. We went super medial and there was the very small cancer. We put a wire in it, removed it, and sure enough, it was a cancer. So this is my last case study, and this is what we'll have a few more of these on the 23rd for you. But this is a normal screening mammogram. This is a lady with dense breasts, between C and D density breasts. So she had a normal mammogram here on September 6th, and then she knew about the dense breast. So she asked for a supplemental breast ultrasound screening. She got booked at the clinic with an ABIS exam, and they came across this abnormality in this breast that was called normal just a couple weeks before. So she went in, had her ABIS, and we're like, wow, okay, we see this. So then the radiologist from West Coast right away ordered a left tomo and a left breast ultrasound plus or minus biopsy. She came in, we did the tomogram. Here you can see, so this is one of the slices of the breast that shows the cancer. The cancer was here in the very medial part of the breast. Still, we're not seeing it on the MLO. So we're like, well, we know for sure we're going to tell the ultrasound technologist to look medial. So that demonstrated an irregular spiculated high density mass only seen in the medial breast, not seeing it 100% in the MLO. So we did the ultrasound of the medial breast, and yes, here we are finding an irregular, taller than wide mass, hypocloak with a little bit of color flow, and this is the biopsy we did. So because this area was so subtle, we did biopsy it, we left a tissue clip in it, and then I redid the mammogram with the tissue clip, and you can see here's the tissue clip in the CC, and it's right here on the edge on the MLO. So that cancer pretty much, it's very far medial and almost goes right off the breast. So, you know, this is going to be a real challenge to see this on a screening mammogram with someone with dense breasts. And this is where the breast ultrasounds, supplemental breast ultrasound screening, we're catching those cancers that unfortunately we can miss with dense breasts on a screening mammogram. So this was also the MRI then that we did of this same patient, because we knew that we had this very small little cancer, and it is very deep. But we did find the 8mm enhancing irregularity, and we did biopsy this, ended up being an invasive cancer, and it was taken out. So here's our specimen radiograph showing the cancer with the tissue clip, with the wire right there, which we inserted that wire with ultrasound, and we know that we've got the lesion out of the breast with clear margins. So that was a great case. And sorry, I went a little bit over time, but thank you for your attention. And yeah, this is just a cute little Instagram card. So make sure that you are getting your mammograms if you're over 40. Jen, is there any questions that I can help with?
In the chat so far, we've had none. If you do have a question, though, you can either speak up right now or put it in the chat, and we can have Tammy answer. And yeah, that was so informative. Thank you so much, Tammy.
Yeah, and feel free to email me, just tammy.clark@islandhealth.ca, and I do have a very condensed version of the mammogram ultrasound correlation, so if anybody wants that, I'm more than happy to send that your way, and any questions, ask me or ask your mammographer at your site, and I'm sure that they can help you with the correlation piece.
Awesome. Well, thank you so much, Tammy. We're just a tiny bit over time. So far, no questions, just lots of thank you, Tammy. That was great and that was awesome. And yeah, if you do have a question, you can email me or Tammy going forward. But for now, I think we'll hop off, and then if there are any questions, we can do it at a later date.
Okay, thanks everyone. Nice to see you. Bye.
Awesome. Thank you.